Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting and we're coming to you from Meanjin, the land on which this podcast is being recorded. In this three-part mini-series, we're talking about in-utero surgery with Dr. Glenn Gardner, a maternal fetal medicine specialist and director of the Mater Centre for Maternal Fetal Medicine at Mater Mothers Hospitals. This episode is about Spina Bifida, which affects about 150 babies born in Australia every year. Glenn was the first to perform this surgery in Australia on a 24-week-old in-utero baby in 2016.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
It was in 2016, that was that first surgery with your team from Mater in collaboration with a team from Vanderbilt University Hospital in the USA. It's been a while, so what has changed since then and how many other specialists are performing this surgery?
We're heading into 8 years now of this program, and we, since that first case with support of the US team, have gone and offered this across for all patients across Australia and also New Zealand. So we've now done 21 cases, I believe, on the last count, and in that time, all alive and doing well, which is good to report. So no one else is doing it, and I think it's very hard to undertake this type of surgery. It's better to concentrate your expertise. We've got a great team here. We now have, the ability to do the surgery not reliant upon single people. So we have enough kind of critical mass so that should someone be sick or someone away, the surgery can still be performed. And that's important for succession planning into the future for a procedure that you're the only place offering it. So we're confident going into the future that for patients across Australia and New Zealand, we'll be able to continue offering this service. It's not really funded by anyone, but the Mater chooses to provide funding so patients don't have to pay to have the surgery, which is very nice as well. There are some costs that would be involved for patients having to relocate here to have the surgery, but we would return them home as soon as we can.
That is wonderful. There was a lot of attention at that time, a lot of media attention on that surgery, a lot of people talking about it. Can you briefly describe what that was like to go through that surgery and have that spotlight so brightly on you at that point?
Yeah, like I had been overseas and had been in theatre both in the US and in Europe, so I kind of already had a pretty good understanding of the surgery. Actually performing the surgery is a different experience. You know, it really comes home not only the potential to improve the outcome for that particular child and the family, but actually what you're undertaking in terms of risks as well. So it's very sobering. I probably aged more in 2016. There's a lot of stress when you do something new like that, and the media attention. I wasn't expecting. I mean, I knew there'd be some, but certainly, across the country there was interest that was kind of a little bit beyond what I imagined. But I think people's imagination is piqued when you say you're actually opening the uterus and operating on a baby and then putting it all back.
It really is extraordinary. If we take a step back now, why does spina bifida occur?
It's a good question, and we haven't actually nutted out the cause of spina bifida. The theory at the moment is that there probably is some candidate genetic genetic basis for the condition that's affected by the environment. There's no single gene. There's no kind of test that you can say someone's going to have a baby with spina bifida. It's a multiple factors all coming together. It's also affected by folate metabolism. So we know that women who take folate around the time of conception and in the first few weeks of pregnancy does confer some protection. It doesn't protect every pregnancy against spina bifida, but it's intricately involved in how spina bifida occurs.
When is it diagnosed and how is it diagnosed?
So traditionally it was diagnosed at the routine morphology scan, which is kind of mid-pregnancy, about kind of 20 weeks. Nowadays, we've got markers that we can look at as early as 12 and 13 weeks. And whilst we're not keen to make a diagnosis, we can actually bring those patients back sooner and make the diagnosis at around 16 weeks. We can be very certain of the diagnosis. And the point of making a diagnosis at 16 weeks is that you can start the counselling process, and the shock of that diagnosis, is not lost on me still today when I see patients. Most patients would be expecting a healthy baby, and there's a lot of time that's required to digest that information, explain what the outcomes are possible for their child, and now, of course, what can we do to make those outcomes better?
Well, if it is earlier at 16 weeks, what can we do apart from counselling? Is there any treatment, any scanning that will make the process better?
Yeah, so it's about time. And so if we are planning surgery at 23, 24 weeks, there's nothing worse than having the diagnosis made a couple of weeks before, because that family have not had adequate time really to come to terms with what their options and choices are. Not everyone continues the pregnancy, and that, as difficult as that is for couples, we understand that, and we think the time is important for them to really, and we get them to see a lot of people. They don't just see maternal fetal medicine. They get to see doctors at the children's hospital that care for children with spina bifida. They get to see a neurosurgeon, a neonatologist. So we really do make sure that they have the best possible information before they're making what is probably one of the most difficult decisions in their life. Will they go forth with the pregnancy and consider having surgery which has risks to improve the outcome, or sadly, some choose not to continue. So
you've made with either 16 weeks or 20 weeks, we know that a spina bifida is present. Talk to me about the surgery. So that happens 24 weeks?
Yeah.
And so why that time frame, and tell me about the surgery.
So the principle of the surgery is to close the defect on the lower spine so the nerves are protected, because the concern is that in utero, those nerves are damaged by exposure to amniotic fluid and rubbing up against the side of the uterus, such that if we get skin across those nerves, there's less damage. And that's been shown on animal studies, and now that we're doing the surgery, we see it in the children. We would love to be able to close that defect earlier, but we're limited by the fragility of fetal skin, and also entering the uterus at that early gestation and doing such repair has been shown to be detrimental. So we have to wait for a time where the skin integrity is enough to cope with the surgery, and that generally is from 22 weeks.
What are the complications from surgery?
The biggest risk is preterm birth. And on average, if you have this surgery, you'll deliver at 34 weeks, compared to if you don't have surgery with spina bifida, we recommend delivery at 37 weeks. So on average, 3 weeks earlier. And whilst that might seem acceptable, and I think it is acceptable for a number of patients, if it was you having a baby much earlier than that, then your child may then have consequences of prematurity in addition to spina bifida. So hence why it can be a very difficult decision. We do a lot to prevent early delivery, and our cohort of cases that we have at the moment, we do run on average about delivery around 34 weeks. And that degree of minor prematurity is acceptable. We wouldn't expect major long-term kind of consequences of that. But of course, even that first case that we did with the US team delivered under 30 weeks. And that's, that kind of rams home very, very heavily, the consequence of this surgery sometimes. Yeah.
Are there cases when surgery isn't appropriate?
Yeah, so there's very strict criteria. Some of those criteria have been relaxed over the years. The criteria were based around a big study in the US published in 2011 now. And there are criteria like even high BMI, high body mass index, may preclude the option of surgery just because we're concerned about surgical risk to the mother, things of that nature. The defect on the fetus is very important as well. So if it's a very minor defect, we would not undertake the surgery. They're the major kind of reasons why we wouldn't be able to operate.
For the in-utero surgery that is completely successful, what care, concerns and treatment happens for the mothers up until they deliver?
So we watch them very closely. We see them regularly in maternal fetal medicine, where we scan them with and make sure that the operative site on the uterus and on the baby is intact and remains so. We monitor the growth of the baby. We plan delivery at 37 weeks as we would for anyone with spina bifida, and that has to be by elective caesarean section because of the scar on the uterus is too dangerous to have labour with in case it come apart. And then we hope for the benefits of the surgery, which are, to avoid a shunt. And some babies with spina bifida need to have a little shunt put in their brain that drains fluid to keep their brain from being compressed by fluid. You halve the rate of need to shunt children if you do this surgery before they're born. The other benefit is you increase their ability to mobilise without needing any assistance. And whilst that's perhaps a secondary benefit, it's an important benefit for children who perhaps would have been relegated to wheelchair only, may be able to mobilise and that have a different approach to how they get around.
Make a huge difference.
Yeah.
What is the role of the GP in terms of prevention and diagnosis of spina bifida?
Yeah, so GPs are very good at making sure that patients have access to ultrasound early in pregnancy. It can be tricky if a patient presents very late, not knowing they're pregnant, but GPs do their best to get the necessary, and everyone usually has a scan at around 12 or 13 weeks now, and then another scan at 20 to 22 weeks. And generally, we will diagnose it. If anything, of all the possible fetal abnormalities that can exist, spina bifida is readily diagnosable on ultrasound. I mean, it's not like we're missing it. And like I'll give you, a classic example would be cardiac malformations in a baby are very hard. And even in the best hands, they can sometimes be missed.
Now, there's so much interest in the work you're doing, so we've asked some GPs to submit their questions. So here's some specific ones for you. Fetal surgery for spina bifida has been happening at Mater, as we've discussed, for a few years now. What are we seeing in terms of immediate and longer-term outcomes after surgery? And you sort of touched on this a little bit earlier.
Yeah, I mean, some of the benefits we see, we only realised after we started doing this surgery. Some of the short-term benefits were that these children don't actually need surgery. They go to the ward with their mother, and like most other babies are born in the hospital. The other children that either don't have surgery or can't have surgery have to go to intensive care. They have to have surgery planned because you can't leave their back open, exposed. And that separation, you really appreciate the benefit of having the surgery done, and the baby goes home at the normal time and has follow-up in the children's hospital with the great rehab team there at the Spina Bifida clinic. And so that's a very great short-term benefit. Usually, if you don't have a shunt inserted in the first year of life, you'll be free of a shunt forever. That's a general truism. And so we've seen already in our cohort of children that have had surgery a very low rate of shunting, so we're very pleased about that. It's not zero, but we wouldn't expect it to be zero. We just want to see a significant benefit of reduced shunting, of which we've seen. And these children are generally very mobile.
There's another question about the timeframes, which we have discussed as well, about the earliest. But what about the latest that this surgery can be done?
Yeah, so generally in the original trial, the latest gestation was 25 weeks and 6 days. That has, we've actually done a case at 26 weeks just recently based on approval from, we kind of discussed it with the US, but she came from New Zealand and was at a later gestation and really wanted to have the benefits of the surgery. And we felt that for the sake of, it was 5 days over our usual limit, and the US team said that they would offer the surgery and have done in their own setting. So we felt confident to proceed. But generally, a week beyond that, 26 weeks would be our limit for repair.
Internationally, how are we sitting in this space, the work that you're doing, the work that we're doing in Australia? How are we faring?
Yeah, very well. I mean, if we look at the world and we look at, for example, the UK, like we were doing the surgery before the surgery was offered in London.
Wow.
Yeah, so we were very much ahead of the game. They've started their program, and I've done some training in the UK earlier in my career, so I'm very much in touch with them as they kind of set about their program after us. Within the kind of Asia-Pacific region, we are really the only centre, and it's, as difficult as that is, it's we're supporting Malaysia at the moment. They want to start a program, and the team from Malaysia has been here to observe 2 surgeries, and then our team will travel, a bit like the US team supported us. We'll be travelling to Malaysia to support them for their first case as well.
Helping all those Malaysian children. That's great.
Yeah.
Great to hear. Now, finally, 3 quick questions from me to give everyone listening an insight into Glenn when he's not at work. Okay, what's on your surgery playlist?
You know what? I do not play music. Yeah, and that's not because I don't like music. I do like music. I've always felt that there's a lot of people in the theatre, and I've never felt that my choice of music should dominate. If the patient chooses to have a playlist, I'm more than happy to play their playlist, whether they're asleep or not.
Yeah, fantastic.
I don't mind. I think that's more important.
It is.
Yeah.
Are you a good dancer, or are you avoiding that question?
Oh, look, no, that's a fair question. When I was young and silly, I would, love to get out on the dance floor.
No time for it now?
No. Now I would, have more reluctance to let my hair down like that.
You and me both. And career-wise, if you weren't doing what you are, what would you be? Were you thinking about trying anything else through school? Or
I always kind of look at some careers and think, oh, I'd love to have done that, or I'd love to have done that. I could have easily been a builder or some kind of technical, non kind of academic kind of role, more using my hands and skills. I would have been very happy to do that.
But medicine was a clear path for you?
No, not really. But I got there in the end.
And you're doing an amazing job. Glenn, thanks again for your time on sMater.
Thanks for having me.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in. See you next time on sMater.